A very good afternoon to all the regional directors, program in charges, students of the PGDGM program and counselors. I welcome you for this last teleconferencing of this year that we will be having for the students of the 2008 batch, and I hope that by now you would have already completed your 4 spells. You may have filled in your forms for the practical term and examination as well as the theory examination. So in case you have any doubts, you may kindly ask your program in charges or the regional directors. You can also phone in and ask us the doubts. Now we have today very important two topics that we will be covering in the teleconferencing today. That will be on the diseases of the eye in the elderly as well as the dental problems in the geriatric population. So for these two topics we have got experts in our dais. I would like to introduce you. To my left is Dr. Devender Sood. He is an ophthalmologist. He is a specialist in glaucoma diseases, and as you all know that glaucoma is a very important cause for diminished vision in the elderly, and so we will be discussing on the common problems, the age-related problems which occur in the case of ophthalmology or the eye, and thereafter I would also request him to tell all of you that how as a physician you should be able to guide your elderlies who come either for the problems of ophthalmology, or you are able to pick up the problems that may be that they may be suffering from in the case of an eye, and how to manage these problems either by giving certain advice or by referring them appropriately to the appropriate place, appropriate person and at the appropriate time. To my right we have got Dr. Amulya Chadda. He is a dentist. He is basically also a private practitioner, and he will be discussing today the various dental problems that occur during aging and dentistry. Now the dental problems we are beginning to find that there are a lot of dental problems that the elderly are coming with because of many reasons. One of the reasons is because of the longevity of life, because of that. Second is that many people, all of us are becoming very conscious about how we look, and we should have our good proper dentition right till our very ripe old age. So how to prevent the problems which may be occurring in the old age and how to manage the problems, I would like him to tell us during his session. Now, to begin with, I would request Dr. Sood to focus on the various age-related problems in the eye. We can first probably begin with that what are the age-related changes that occur with in a person, and then what are the problems because of these changes which may crop up and how to manage them. Dr. Sood.
Thank you. I think the basic objectives of the program today is to be able to define blindness. I think these objectives are essentially for you. And we need to know what the WHO classification for blindness is, how it differs from the Indian classification for blindness. We need to describe some of the common causes for blindness and how they tend to affect the elderly people. And the other emphasis is essentially how we can help our patients to avoid these visual disturbances. And by helping our patients, we'll actually end up being a part of the national program for prevention of blindness. So I think on the whole what we're going to do now is the definitions are a part of your textbook, so you'll find it all there. But what we're going to do is describe some of the common causes of blindness which can cause impairment in the elderly, and see how we can advise and pick up these in the clinic when they come to us, so that we are actually contributing to the national program. So we are a very large country in terms of number of people that we have. We are nearly 1 billion plus, but I think you need to know that people who are more than 65 years of age constitute 10% of our population. And if you look at the number of blind in India, 50% of them are actually people who are more than 65 years of age.
I'm sorry, just to interrupt you 1 second. I would just like to mention over here, as always, please do not concentrate on taking down notes, because you will be getting these videos later on. You can even come back after your session, after your term is over, that is 1 year is over and you have appeared for the exam, you can still take the videos. So please, we have got very eminent experts here, and I would request you that you can please listen carefully to whatever is being discussed here. here, and you can contribute by asking questions as per the cases that you may have come across, the problems that you may be facing in your routine day-to-day practice when you're dealing with the elderly cases. I would request the studio people also to flash the numbers for the toll-free numbers and the fax numbers. In case you have a problem in dialing in, you can always fax and ask the questions. So, sorry, Dr. Sood, I can please continue.
So I think, one of the commonest problems the patient comes to us with, and to you probably, is blurred vision, or maybe there's a decrease in vision. So that's the opportune time for us to pick up these patients. So in the next couple of minutes, let's see what possibilities to keep in mind when the patient comes with blurred vision. So this is how the eye actually looks like, and you can divide it grossly into three compartments. The front part is what we'll focus on, and this is where, when you're crossing 40 years of age, that little difficulty in reading the newspaper, you want to keep it a little further off so that you can read it. That's perhaps the best time. That's presbyopia. It is not a disease, but it's actually a part of the aging process. And these will voluntarily bring patients to you saying they're having difficulty in reading. So that's the time when you need to make sure that they get a proper eye checkup done and other diseases are actually looked into. The other common problem seen in this age group is, it involves the lens. And commonly you have what is called as a cataract. It's the commonest cause of preventable blindness in India. Typically it's a painless, gradual blurring of vision, and colors will not appear to be bright. You'll see colored circles on bright light. The glare, particularly when you have oncoming headlights of a car, they'll appear to be splayed out, and that's what cataract is about. So this is how a cataract looks like. Easy to pick up on a torchlight examination. You just got to shine the torch across the pupillary area, and you'll see this grayish, whitish, greenish reflex, and the cause is basically age related. You can have a number of systemic conditions which can be associated with cataract. You can have a number of medications, particularly the rampant use of steroids, which can lead to forms of cataract even in the younger age group. The only treatment for cataract is surgery. Now, whatever vision is lost from the cataract will come back once the cataract surgery has been done. So that's the thing to remember in mind. It's reversible blindness. The only aim is to pick up the patient early and get the cataract surgery done. Now, over the years, what has happened is technique for cataract surgery has improved, and what we are actually focusing now on is that if you can pick them up earlier, you'll be able to prevent even the economic loss produced because of a reduction in vision from cataract. So as I said, technique has changed. It's no longer waiting for the cataract to mature. The newer technique is based on the sutureless surgery, that's phacoemulsification. So as of now, there are two broad indications for cataract. Patient comes and says, I'm having difficulty, and you feel that it's because of a cataract. Surgery is required because we normally don't wait for the lens to harden, because if it hardens, the sutureless surgery takes place through a small incision, so it gets difficult to remove the cataract. The second indication is when the cataract is becoming hard. So again, because surgery is going to be done through a small incision, we want to pick up our cataracts early and have them replaced with an intraocular lens. This is what an intraocular lens actually looks like at the lower part, and most patients actually do very well after surgery. In fact, 6/6 vision is the norm, provided there's no other disease to restrict vision. Other diseases, I think, which we need to look at.
Before we go into other diseases, I would like you to give a little bit of an idea to our students, because many of them have done their MBBS long back. What is the cost of the different types of surgeries in cataract? Because that is one thing which as a physician, the elderly are bound to ask them. Because
I think the cost of surgery will vary depending on the kind of person you go to for your cataract, the kind of lens you get implanted into your eye.
So what is the range as far as the lens is concerned, or the type of surgery? I mean, what is advisable? I know it's a difficult to advise.
The basic thing is, you have to identify why the cataract is getting done. So look at it in another way. You need a mode of transportation. You could choose a Maruti car, or you could use a BMW. So you would need to give the range to your patients. It could vary from as low as about 7,000 to as high as about 70,000. You're going to see the same amount with whatever amount you spend. The quality of vision is going to be different. Yes, the material of contact of the cataract lenses is getting better, and the increasing cost is essentially because of the better quality which is going in, people are becoming more sensitive towards contrast sensitivity. Now contrast is better with some of the newer materials which are being used, but perhaps you could get just the cost of the lens could be as low as 100 rupees or less, and the cost could be as high as 5 to 6,000, just talking about the lens which is used in cataract surgery. So there will be a variation depending on the kind of place you're in. Other diseases, when the patient comes with any general discomfort, 40 years of age, it's the best time to look in for patients who are diabetics. If you are screening them for getting a blood sugar, fasting, or a postprandial done, it's always good to remember diabetics usually have weak blood vessels which have a tendency to leak, and when there is a leakage within the eye, they tend to leak blood and vision can get distorted. So the important thing is, when you're looking at diabetics, make sure you ask for an eye examination where a dilatation is done as a routine and the back of the eye is looked into. This is mandatory. When you see those early signs, you might need to get an angiography done, and when you see these early signs like a leak, you'll get an angiography done. The site of the leak can be identified and appropriate laser can be done to seal that site of the blood vessel, so that further accumulation of this debris or exudates does not take place. So the important thing is, all diabetics need an examination with their eye surgeon, and you are the one who's actually going to ask for it. All diabetics need to be screened once in 6 months to a year's time with the eye specialist, because it's very important. Again, remember, it's preventable blindness. If you can detect it early, make sure the examination is done, the adequate laser is done, then hemorrhages in these patients can be avoided. The other common causes which can restrict vision is patients who have a hypertension, systemic hypertension. They are more prone to develop hemorrhages in the retina, like a venous occlusion. So again, this is where the situation is changing, and early detection, that means a proper eye examination at the time when they come to you for a reduction in vision. That's when you need to get them. When patients come with reduction in vision, just keep this in mind. It's not just a mild reduction in vision they're coming for. Most of them would be having this reduction in vision for quite some time. The typical tendency is to assume that all blurring of vision is because of a cataract. So most patients actually keep waiting for the blurring to take place, that I'll wait for my cataract to mature and then I'm going to go in for a surgery. Now that's usually not true, because other factors like diabetes or for example hypertensive retinopathy, age-related changes like macular degeneration can all contribute to the blurring of vision. This is again to show you, the vital-most point of the eye is what is called as the macula. And this is the macula, and what happens is we have cells in this area. It's a relatively avascular area, so blood supply is very restricted. We have nutrients coming into these cells depicted by the green arrow, and then the waste products which are being excreted out by the cells. As a part of the aging process, the process of exudation reduces, and because of this, more inflow of nutrients and less outflow of the waste material. As a result, you get small whitish deposit called exudates. This is again an age-related macular degeneration. Truly, not much could be done till about a couple of years back, but now treatment has got changed. There are lots of new drugs which can be injected. There are specific lasers which can be done to make sure that this age-related macular degeneration doesn't increase. So important thing to remember, blurring of vision can be for many causes. Cataract is one of them. That's reversible blindness. Diabetic retinopathy, if we can pick it up early and make sure changes in the eyes don't develop. Same thing for hypertensive retinopathy. We can prevent economic blindness from these diseases, which can otherwise be devastating. It can be permanent blindness. Same thing with macular degeneration. You may not be able to prevent blindness, but you can at least slow down the process of loss of vision, provided you as physicians ask for an eye examination at the right time.
How commonly do, you said around 40, of course for cataract normally people will be coming, but then thereafter how frequently is an eye examination warranted for an elderly?
I think 40 plus, everybody needs a complete eye examination after 1 year. An annual eye examination, preferably yes.
Okay.
Preferably.
And as far as macular degeneration is concerned, that means the very old or very old people, especially 70, 80 years, their macular degeneration you feel will be much more?
Yeah, as the aging process, life expectancy is increasing, so some of these geriatric diseases and lifestyle diseases are only going to increase. Okay. So we are now going to see a lot of these diseases coming back in larger numbers in India, because people are living longer. Okay. There's an economic boom going on, so more of them are coming in for proper eye examination, annual checkups, and more diagnosis is taking place. Let's move on to another cause of blurring vision or blindness, which is commonly seen, that is glaucoma, also called as kala motia. So depending on the kind of area you are, if you're in UP, they'll call it samalbai. So all this will vary. The important thing is the loss of damage in the loss in glaucoma is irreversible, and it typically produces, this is what we all see, a bridge. But a glaucoma patient progressively over a period of time will have a narrowing of his fields. Now this narrowing of the fields can interfere. For example, a person with glaucoma is driving and he sees somebody cross the sidewalk which normally would have been seen. But because his field is restricted, he cannot see the other person crossing the road and is more likely to hit that person. So the important thing to remember that in India, 1 in 80 are blind from glaucoma in both eyes. 1 in 30 are blind from glaucoma in one eye. And by the time they are seen by an eye doctor, 1 in 7 are afflicted by glaucoma. So the important thing to remember, glaucoma is one of the leading causes of preventable blindness all over the world, and this includes India.
What is the common age of appearance of the glaucoma?
Typically 40 plus, but glaucoma actually doesn't have a bar. It could present in a newborn of 1 year right up to the very end. So yeah, usually tends to happen 35, 40 plus in this age group. Now all these situations that I have discussed, it's usually lack of awareness, because as I said, most patients keep waiting for the blurring of vision. They think it's because of the cataract and they're waiting for the cataract to ripen. Now we've got to remember as physicians that if any patient tells you about a blur, you've got to keep in mind that something other than cataract may be involved. It could be a diabetic retinopathy changes, it could be a hypertensive retinopathy, it could be a age-related macular degeneration, it could even be glaucoma. So awareness is the most important. Awareness not just for the from the patient's perspective, but the doctor, the treating physician to whom the patient comes, because he is the one who's going to channelize the patient to the next step. So just to summarize, I think the aging eye can have lots of changes. You can have just a change in the power of the glasses. Typically for reading, that's not a disease but a part of it's a physiological process. Then you could have a loss of the natural transparency of the crystalline lens, that's cataract. You could have changes in the back of the eye as a part of the systemic diabetes or hypertension. You could have a macular degeneration and glaucoma. So we are all going to, as life expectancy increases, we are all going to experience problems or difficulty with our eyes. But the important thing to remember is good vision can usually be maintained for life with professional eye care. I'm not saying send patients to me, but I'm just saying ask for a good complete eye examination whenever a patient comes 40 plus. Make sure that they've had an annual checkup done at least on a regular basis.
Like we have prevention for many of the diseases. Now for the eye diseases also, is there any preventive eye care that can be done for preventing the diseases to occur, or
I think the
is
best,
just the checkup which is...
Yeah, I think the best prevention is that if you are likely to develop a disease and you can pick up some of the early signs, appropriate treatment is started, then you can prevent further damage.
Okay. But otherwise food or exercises or something, they don't have much role to play?
Scientifically, perhaps it's very difficult to say. For example, we say people have a high minus number, so we say it's probably because of a nutritional deficiency. But a large number of people who have high minus numbers come from good socio-economic strata where deficiency is unlikely to be a factor. So maybe it's genetics. But a lot of people have wearing glasses, don't have parents or anybody else in the family. So there's no clear-cut scientific evidence. There are probably risk factors, but no clear-cut evidence to say if you take this, you're going to feel better. If you take this, you're going to worsen. So that kind of clear-cut scientific data is not available. So if you have a patient who comes in and says, I'm having a drop in my vision, remember that drop in vision can be prevented or at least arrested, provided we are able to diagnose it on time. Now there are a lot of things we can say, we shrug off. How many of us have had a chest pain and never got an ECG done? Why patients? It's about us doctors. And I can just recall there's a population-based study from England which said that most patients who were 65 years of age had breathlessness and exercise-induced tolerance, and they had just shrugged it off as a part of the aging process. Now the important thing was this was an asymptomatic airway disease, and when they were given beta blockers topically, it precipitated an asthma. So as the age group increased, the likelihood of developing an irreversible airway disease increased, and when they did a retrospective analysis, they found that most patients had been having some sort of chest discomfort, which they would never tell their physician because they thought it was a part of the aging process. So that's the important thing to remember. Whatever discomfort the patient comes to us with, let's not take it lightly, because for ourselves also we would not like to take any of our discomforts lightly. So that's the same benefit we need to give to our patients. Now, if you look at a normal eye, this is what a structure of a normal eye looks like, and this is how light forms and it's focused onto the back of the eye. We get an inverted image, and when the light falls on the retina, there's a chemical reaction which takes place, as a result of which small electrical impulses are produced. It goes all the way up to the brain, and then electrical impulses come from the brain back to the nerve, which says, asking the eye to follow whatever light stimulus was shown. So that's how typically the eye functions. Now, as I told you, glaucoma is one of the leading cause of preventable blindness all over the world. Unfortunately, a large chunk of this preventable blindness is in developing countries like India. In fact, current data shows that India is going to be the hub of glaucoma in the next 10 years' time. Glaucoma, which is essentially preventable blindness, and as of now 12 million people are affected by glaucoma, accounting for nearly 13% of the blindness in India. So glaucoma is essentially a disease where you have damage to the nerve. It may or may not be because of a high pressure alone. So just to show you the structures of the eye, this is how the eye looks like from the front. All you got to do is shine a torch and see the reflex. You'll be able to pick up the cataract changes. Now if you look here, you see the structures, and as I just blow it up, you have ciliary processes here. Aqueous forms in this area, back compartment, flows through the pupil, comes into the anterior area, and then it flows out. If for some reason there is an obstruction to the flow of this aqueous, you have an increased pressure on the back of the eye, which tends to damage the optic nerve. So you can just show you the optic nerve progressively getting damaged over a period of time. And because of the damage to this optic nerve, you have this gradual narrowing of vision. Remember, the damage in glaucoma is irreversible, unlike cataract. So the symptomatology is usually the same: blurred vision or reduction in vision. So if the patient has cataract surgery is done, vision will improve. But if the patient actually has a glaucoma, then that vision improvement will never take place. So never take blurred vision or reduction in vision lightly, because sometimes it could be because of an irreversible cause like glaucoma. Glaucoma has several types. There's an open type, and I'm not going to go into the pathomechanism, but I'll just tell you that the open type usually presents with symptoms only in the advanced stages, and that is blurred vision, exactly like the way cataract presents to us. And then we have what is called as the closed variety of glaucoma. Now this kind of glaucoma typically presents with pain, redness, and colored circles on bright light. Unfortunately for us Indians in the Asian continent, this kind of glaucoma presents more without these classical symptoms. So again, it will present more with blurring of vision. The reason why we differentiate the open and closed type is that treatment for these two conditions is entirely different. In the open type, we treat with drops, and if that doesn't work, we go on to surgery. But because in the closed type there is a mechanical obstruction, if we do a laser iridotomy as indicated by the green mark there, we will create an alternate passage for the fluid to pass out. Now laser iridotomy is not a surgical procedure, it's a non-invasive procedure, so can be done very comfortably, gives good success rates provided it is picked up on time. And I'll come and tell you how as physicians you can contribute in reducing the blindness from this particular type of glaucoma. So again, there's a third variety of glaucoma, which is the pediatric variety, the developmental children presenting with large eyes. Now large eyes in India is usually synonymous with beautiful eyes, but remember, large eyes can also harbor a glaucoma. Eyes which have a bluish tinge to them could be glaucomatous, as you see in this child. So the approach to this is entirely different. We won't spend much time on this because we are focusing more on the geriatric disease. You can have glaucoma as a part of something, so as a part of some surgical procedure, as a part of trauma, as a part of certain medications. But remember that blindness from glaucoma, it's a slow chronic process, while usually the angle closure variety tends to present as a medical emergency where there could be a severe nausea and vomiting. A physician could mistake it as a part of a GI upset or a GI discomfort. So symptoms, as I told you, typically the open type presents with a gradual decrease in vision, just like what you have in cataract, but the closed type, pain, redness, and colored circles around bright light is very common. It's possible to have glaucoma without symptoms, so I think the only way to remember is any reduction in vision, any blurring of vision, you have to get an eye checkup done to rule out other possible causes. Now, glaucoma is a disease to remember that once vision is lost, it will be lost forever and cannot be recovered. So that's why glaucoma is called the sneak thief of sight. How do we prevent blindness from glaucoma? The key word here is, there's a statement we were all taught as children: a stitch in time saves 9. So this is where it works well. If you can pick up the glaucoma early, you can prevent further damage. So in glaucoma, we never talk about a cure, because cure means reversal. We cannot reverse damage, but we can talk about prevention in the sense we can prevent further damage from happening, provided the patient gets a complete eye checkup, and that means you ask for a complete eye checkup when the patient comes to you for a blurred vision, so that it can be done now. Perhaps the best time to get the eye checkup done is when the patient comes to you with that difficulty in reading close to 40 years of age. There's a rapid change in the power of glasses. Patient says there's a family history of glaucoma, diabetes, hypertension, thyroid. Patient has used steroid-containing medication in any form, be it tablets, eye drops, puffs, ointments. A steroid-containing medication applied on the toe, if the patient has a genetic susceptibility, it can lead to a rise in eye pressure also. So I think that's the thing to keep in mind. Patients whom you're prescribing sleep medications, medication for anxiety, because in patients who have narrow angles, the close kind of glaucoma can be precipitated. Patients who are asthmatic, even the adrenergic salbutamol can actually precipitate angle closure. Drugs for Parkinsonism, because in glaucoma we often give beta blockers, so that will cross-react with some of the medication used for Parkinsonism. Any injury to the eye, and patients who have headaches should never be taken lightly. So detection is very simple. Glaucoma basically involves, and this is what a complete eye checkup should also involve, you check the eye pressure typically with an instrument called the applanation tonometer, which uses blue light. You make sure that you look at the status of the optic nerve at the back, and I'm sure as physicians you're hopefully doing it for your patients. You're supposed to do it in patients who are hypertensive to pick up that hypertensive retinopathy, and look for hemorrhages, look for other changes here, and you could ophthalmologists at least resort to advanced testing to pick up and follow these changes over a period of time. Now, the field test is a very important test, should never be taken lightly. You may have a patient with migraine, you may have a patient who just has a headache. Any lesion from the eye all the way up to the brain can produce this. So you need not expose your patients to any radiological exposure. All you need to do is get a field test done and you'll be able to pick this up. So these are perimeters which are used to perform a visual field test. What does it involve? It just
field test. I just wanted to ask you, field test can be done only by an ophthalmologist, or do you feel that in the community it is also possible by the general physician? It's possible. You have simple bedside confrontation tests which can be done, which gross hemianopias can be picked up. When you're looking at a geriatric population, they'll have age-related cerebral atrophy happening. They could have an hypertensive episode which could have some sort of a hemorrhage in the brain. You could have, say, a multiple sclerosis producing changes. So some of these changes are actually picked up from this, and confrontation tests work very well. But when you're following a patient, for example, a patient who has a neurological disease or an operated pituitary tumor, you need not get a CT scan or an MRI done repeatedly. You could just get a visual field done every 6 monthly, which is what most neurosurgeons prefer, and follow up the patient repeatedly. Okay, at this point I would also like to request the students that we are not getting any calls today, so kindly, I know it's a very engrossing and an interesting presentation, but still there may be a lot of doubts in your mind and a lot of queries, so you please do dial in and ask the questions, because we will stop the presentation in between and answer the questions. Thank you.
So just to show you what a visual field printout looks like, and this is a patient who typically came with a headache and a suspected glaucoma. When the fields were done, there was a temporal involvement in both the eyes, and when we asked for thinking in terms of a neurological lesion, we found out that there was an old PCA infarct which was involving the parts of the brain. So this by itself told us that this patient had a neurological problem and needed to be put in touch with the neurophysician. So again, other situations where fields would be required are patients who have a rheumatic arthritis. They have been on chloroquine therapy for some reason. It can cause what is called as a bullseye maculopathy. So these are situations where in the early stages, typically this drug tends to get concentrated in the macula, retinal pigment epithelial cells. If this any blurring of vision in a patient who is on chloroquine, if they complain of any doubt also about blur of vision, it's good to get the fields done, get this documented, and take the patient off chloroquine, because this is reversible in the early stages. But as the amount of drug intake increases and the blurring progresses, this can become irreversible. Similarly, other drugs like what is used for treatment of tuberculosis, rifampicin, INH, all these patients would need frequent monitoring. Patients who have a breast carcinoma and are on tamoxifen, these are patients again who would need visual fields periodically. Any blur of vision or maybe a transient blurring should never be taken lightly for these patients. So just to emphasize, fields will play a very important role in these situations. The fourth thing, we talked about pressure, we talked about looking at the optic nerve, we talked about the field test, and now we're talking about an instrument called gonioscopy. This is the only test which is going to help us differentiate an open variety from a closed variety of glaucoma. And treatment is different, and therefore every patient with glaucoma, we need to know whether it's an open type or a closed type. So a complete eye examination, that's what is going to help us detect a glaucoma. That's going to help us detect other age-related diseases which can mimic glaucoma. So we need to get the vision tested, we need to get eye pressure, take a look at the optic nerve and visual fields and gonioscopy wherever it is required. Treatment, as I mentioned, is different for different kinds of glaucomas. You can't depend on symptoms alone, because symptoms either happen when the disease is very advanced, or they typically tend to happen when they're usually absent amongst us Asians. So this is how gonioscopy is actually done. Now, treatment for glaucoma involves medication, it involves lasers, or it could involve surgery. The algorithm followed will depend on the kind of glaucoma, the severity of the glaucoma, and the patient, who has to be compliant with the treatment you prescribe. But remember, the primary goal is to preserve vision. And we can use medicines which reduce the amount of aqueous coming into the eye or allow more aqueous to leave the eye. But medications can produce side effects. As you see, this gentleman, he has red eye. It's not that he's had a drink too many, it's just that he has used medication, an adrenergic agonist, which is producing this redness. There are medications which can change the color of the eye, the brown part, the iris, and this is not a malignant change. It just represents a proliferation of the melanocytes, which is not carcinomatous. There can be an increase in the length of the eyelashes. You can have a periocular pigmentation, as you're seeing here, with some of these medicines. And some of these medicines can also produce rashes, particularly systemic acetazolamide. So we got to be cautious of all these things and make sure, even in fact, medications can also produce what is called as drowsiness, and typically we have glaucoma patients who are so happy with their medicine, they typically say, when I put the drops and start reading the newspaper, I fall asleep in 10 minutes. And when you tell them, no, this is a side effect, it's not an advantage, because it's not good to move around with drowsiness, they get very unhappy when you take them off this medication. But remember, as physicians, systemic medication can raise the intraocular pressure, just as some of the medications for glaucoma can produce systemic effects. So we got to be very careful and make sure that we ask our patients for a proper history before treating them. Glaucoma is a chronic disease, but it's possible to preserve the patient's lifestyle. Gone are the days when pilocarpine and timolol were the only modes. Today we have 64 permutation combinations available to treat these patients. Laser is an option, but the laser for the open type of glaucoma is not cost effective in Indian eyes. The closed variety, now this is very important for us, because the closed variety is much more commoner in Indian eyes. We'll come back to the data and show you, but the closed variety needs to be treated as a first step with the laser iridotomy. It's only then that you go on to some other procedure. So this is how a laser iridotomy looks like. It's just it's about 100 microns in size, placed under the upper lid and doesn't disturb the patient in any way. Other options include a glaucoma surgery. So treatment is challenging in glaucoma or any chronic geriatric disease, because in a scenario like India, insurance usually doesn't pay for the cost of treatment. Geriatric people are usually dependent on their children for the money to buy medication. It's unfortunate, but that's true actually. and very often the children are staying abroad. So you'll typically have patients who will call you, their children will call you November, December saying, how's my parent doing because I'm coming back in India and I would like to schedule a checkup with you. So these are some of the problems. They won't come and suddenly they'll come on a yearly basis when one of the children is with them. Glaucoma can occur in any age group. It tends to run in families. So if you have somebody who has a glaucoma history, be very cautious in giving them steroids. Make sure they get a proper eye examination done. Treatment in glaucoma is usually for life, and there's no way of knowing that the treatment is working. You have to get the patient back to the eye doctor, and he's the one who will decide whether the medication is working or not. The other important thing in glaucoma is most body parameters are never constant. For example, the blood pressure in the morning, afternoon and evening would be different. So likewise, the eye pressure will be different. There's a diurnal variation of intraocular pressure over a time, and this needs to be kept in when we are trying to prevent further damage to the optic nerve. So there are lots of newer technologies available in India also, where we can look for early changes before they become they start manifesting for the patient. Fields is another way of looking at it. So as I told you, 12 million are blind in India and accounting for 13% of the blindness. Now if you look at Caucasian eyes, the open type of glaucoma is 5 times more common than the closed type. On the other hand, if you look at Burmese or Chinese eyes, the closed variety of glaucoma is 5 times more common than the open type. And amongst us Indians, if you look at hospital-based data, it occurs in a near 1:1 ratio. The other difference we have as compared to Caucasian or Chinese eyes is the closed variety, which in the textbooks is typically symptomatic with pain, redness and colored circles, takes place without any of these symptoms. So, that's the thing to keep in mind. If you are treating a patient who also has a glaucoma, make sure you take a list of his glaucoma medication, because some of them are likely to interact with his systemic disease. We don't normally ask for lifestyle changes in glaucoma or some of these age-related changes, some of these age-related diseases of the eye, but it's always good to look into certain postures like Halasana and Sarvangasana, because any exercise where the head goes down is perhaps not good where you have a circulatory disorder involving the head. I think this is very important as physicians. Avoid giving steroids for small complaints, whether they are eye drops for red eyes or they are ointments, puffs or tablets. Find out the cause. I mean, very often dermatologists will go on to steroid-based medicines in combination with antifungals. We've got to be very cautious. Make sure that when we are starting sleep medications like Compost, Valium, Alprax, antidepressants, antihistaminics, make sure that we've just held the torch in front of the patient's eyes to make sure that the chamber is not shallow. It's a simple bedside test we can do to look for an iris shadow. If there's any doubt, make sure we send the patients to the ophthalmologist for an eye checkup. Dyes have been known to produce glaucoma because of constriction of the carotid circulation, but I don't think it means that we shouldn't wear ties, but we just shouldn't tighten our ties too tightly. And glaucoma is not contagious. It doesn't represent a cancer either. So the important thing to remember is you can wear your contact lenses, you can carry on with your day-to-day driving, provided your field of vision is not restricted. In moderation, you can have it, or at least glaucoma patients can have it. No dietary restrictions. This is very important from a systemic point of view. Mustard oil is typically contaminated with a drug with a medication called Argemona mexicana, and the poisonous component is sanguinarine. It produces a swelling of the feet, pedal edema. It produces an anasarca with blurred vision and a rise in eye pressure. Now, patient may not realize the blurred vision. He'll come to you as a part of normal hemorrhages all over the body. It will never affect a single person, but it will typically involve the family, because the community where that particular type of mustard oil is used will be affected. Delhi has had 3 episodes like this. It's called epidemic dropsy actually. So remember that you have people who have mustard oil as a part of the routine. Typically a lot of people in India tend to have that. Swelling of the feet, any other swelling on the body, an eye examination should always be done in these patients.
And also like you to, cancer is one thing which we normally, associate with all geriatric population as far as the rest of the systems are concerned. But ophthalmology, you have till now not spoken anything about the malignancy part. Is malignancy common or not that common in ophthalmology?
I think we are most of the time looking at secondaries which are coming into the orbit, and primary malignancies, fortunately because of our high melanin content, we are protected by.
Okay.
So It's not that it doesn't happen, but
Not
it's
that
very
very
uncommon.
common as far as the
Not
other
very common.
diseases
Yes,
are concerned.
not very common.
Okay.
I think the newer thing is that we are beginning to realize that ganglion cells need to be protected. There are several ways of trying to protect ganglion cells. The next advance in geriatric medicine is going to be the role of genetics to be able to tailor the genes so that a disease can be prevented in the long run. So that perhaps going to be the thing. We're getting into more and more of gene mutations and understanding them. Gene replacement therapy is on its way on, and I think maybe there won't be any more doctors, but there'll only be gene specialists in the years to come. So just to summarize, blurred vision can be for several reasons. One of them can be glaucoma, and blindness from glaucoma is usually asymptomatic. You've got to ask for a regular or a complete eye examination. The best time is when the person's more than 35 years of age, having a rapid change of glasses, family history of any eye disease, diabetes, hypertension, thyroid, patients who's on steroid containing medication, patients who are on medication for sleep, anxiety, asthma or Parkinsonism, any injury to the eye. You've got to ask for a complete eye examination where you specifically would like the vision, the eye pressure, the back of the eye, including a fundus examination to be done, if required a field examination. Make sure gonioscopy is done in the context of a glaucoma. We don't normally ask for lifestyle changes as far as the disease is concerned, but the important thing is periodic follow-up would be required. How can you help? By making sure that your patients who come to you with blurred vision, patients who have a systemic disease like diabetes or a hypertension, get to see their ophthalmologist so that an eye examination is done. Make sure that they get periodic eye examination done if they are diabetics, hypertensive or have any systemic anomaly which can affect the eye. Make sure that you don't use steroids for small complaints, and patients who are going to be prescribed Campos, Valium, Alprax, make sure that they don't have shallow anterior chambers. Patients who come with headache, don't take them lightly. It could be a refractive error, it could be a raised intraocular pressure, it could also be because of a neurological disease like a pituitary tumor. So make sure that they're evaluated by an ophthalmologist as a part of the routine. I showed you this example just to say how you can pick up age-related changes in the brain as a part of just a visual field examination. So make sure patients who are on certain drugs like chloroquine, INH, rifampicin and tamoxifen get periodic visual fields done. Talk to your other friends and make sure that any of their patients who has a blurred vision at any point of time, even if it is transient, gets his eye examination done, particularly the visual fields is done over a period of time. Thank you.
Thank you very much, Dr. Sood. I think you've made a very comprehensive presentation, and I think you've also done my job by summing up your presentation. But I would just like to say one or two points, and that is that we as physicians, it is very important for us. We cannot do what the ophthalmologist does, but we can always be an important bridge between the elderly and the ophthalmologist. In that we have to be careful about 2-3 points, and one is that we should know that when and at what age screening for particular patients are important. Every elderly, as has already been mentioned, either around 40, 45, or when they start experiencing blurring of vision, which may be because of cataract, should see an ophthalmologist. Second, whenever and at any time they do have blurring of vision, they also need to see a complete ophthalmological examination, especially in an elderly, because it could be because of some other reason than the cataract, for example glaucoma. It is also very important that we do ask specifically the elderly when we do prescribe certain medications whether they do experience blurring of vision, because it may not be that they come up with such a complaint, because they may feel, as we already know, that they may feel it's a part of aging, that we are having the blurring because of cataract. So it is very important specifically to ask for this complaint when we give certain medications. And it is also very important that when they are suffering from certain diseases like diabetes and hypertension, that we do require a more frequent eye checkup to pick up the various pathologies which they may be suffering from. So we as physicians have a very important role to play as far as the disease, the eye problems related with the various systemic diseases and the impact that the various medications that we prescribe which may be having on the eye pressures. So I think, is there anything else you would like to add, or I think
the only thing, you use the word screening. I think so you can have screening in the population-based screening, or you can have opportunistic screening for patients who come to the clinic to see you.
Yeah.
we are very enamored by the economic blindness from various diseases, but I think, you know, a large number of us tend to miss the cases who come to us in the clinic. So before we actually step out into the community, we need to pick up the cases who come to us, the high risk cases.
Yeah.
For blurred vision, diabetics, known diabetics, hypertensives, make sure, asthmatics, make sure that they are have a thorough eye checkup, and they have a thorough systemic evaluation. Once we started picking up those, we need to step out
And
into the
we
community.
also probably need to increase an awareness that there are certain eye diseases which could have a genetic predisposition, so the family members need to be more careful about that. So with that, I would like to thank you, Dr. Sood, and we will take up the dental problems in the next session. Thank you.